I'll start with two thank yous. Tony, thank you very much. Lovely talk. Glad I didn't hear it as an undergraduate or I would have been a pharmacologist. And Bart, thank you for the introduction. So I'm talking about the levels of evidence for and against the use of opioids for the next few minutes. That is a picture of King Alfred the Great, who died in 899. And it's a statue in Winchester. Winchester used to be the capital of England. And according to Wikipedia, he's described as having a reputation as a learned and merciful man of gracious and level-headed nature who encouraged education and his people's quality of life. So not a bad role model for most of us. How do we move on? Sorry. So the plan for the talk, quick introduction, I'll be explicit about my aim. I am going to talk about evidence-based medicine and what it is, so we don't get that wrong. I'll talk very briefly about the background to opioid use, and Bart has touched on some of that already. Talk about the growth in prescriptions recently. We'll then hit the subject matter that you've attended for, the evidence for and against, and then wrap it up with a summary, if I get the buttons right. So, introduction, you really need to all be very explicitly clear that the topic of opioid use in non-cancer chronic pain is really a home of biases, both individual, political and social. And as Henry McQuay once put, the weaker the evidence, the stronger the opinion. And that's to be remembered throughout. Something is not meeting up. So the aim of the talk, I'm not giving a doctrinal policy here, I'm afraid. The primary aim is to provide you the idea of the evidence for and against. But there's a secondary aim, and that's to discuss some of the wider issues that face us as healthcare professionals and things we need to think about when considering the evidence. So what is evidence-based medicine? And I think I can do no better than quote David Sackett from over 20 years ago, almost, who's seen by many as certainly one of the fathers of evidence-based medicine. And he wrote that evidence-based medicine is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. Judicious use of current best evidence and its individual patients, please remember. He thought that this was a combination or a result of integrating your own clinical expertise, which he described as the proficiency and judgment of the clinician, with the best available external evidence. So it's not just reading the paper in Pain that month, and that's the answer. It's the combination of the external and your own experiences is what makes up evidence-based medicine. And I think many of our managers fail to see that. Perhaps should be given the full definition. So a bit of background to opioids. Mesopotamia, 3,000 years BC, probably used initially actually to induce euphoria, so that when you took your hemlock, you didn't worry too much about the death. Not very medical. Morphine was isolated at the start of the 19th century and soon after was marketed, but really for addiction and analgesia. Now that was addiction to other opioids. Codeine, 1832, heroin, diamorphine, the end of the 19th century. Oxycodone was in use by 1917. That always surprises me. I thought it was relatively modern. Pethidine was discovered in a search for a synthetic version of atropine, which is probably why many people don't think it does much. Tramadol, 1977, buprenorphine, 78, and then the new kid on the block got its FDA approval in 08. So as you can see, there's been an explosion of agents available to us, but also the way we view change has changed, I think. Pain has changed. The Zeitgeist, I thought that was rather a good word for a monoglot Englishman to use in Austria. So we've changed the way we view it. In no small amount was this due for us as clinicians on behalf of this paper by Melzack in 1990, in which he suggested that actually a lot of pain could be got rid of if we used opiates properly. There was then, as far as organizations and the structure to our field goes, an increase in exposure. So we had the International Symposium of Pain, and from that came IASP. There was the Intractable Pain Society of Great Britain and Ireland, which I think has got a fantastic name that we should probably resurrect a bit. It had been going for several years already, but became a charity in 1979. And then, of course, we've got EFIC, founded in 93, and now covers 36 countries in Europe. So big changes there, but then there's changes on the other side of the desk as well. So we've got the patients changing, and who hasn't heard this cry from their patients? Something must be done, doctor. And of course that affects us as the clinicians. As Dr. Kathy Stannard has stated, pain sufferers exhibit distress, and this makes us as clinicians feel the need to do something, because persistent pain makes you very distressed. We have to do something big and clever about it, and so we look for something strong, and we get an opiate. So there's push and pull on both sides. Prescription growth, as Bart has alluded, quite significant changes, 1999 to 2010, fourfold increase in opiate prescription in the US. 1997 to 2006, over 6 times increase in prescriptions for spinal conditions. Now, I think there's a great argument to suggest we weren't treating pain very well before then, but clearly eyebrows need to be raised slightly. Per capita of use, Bart showed some numbers earlier. I'll just show mine. This is 2010 data from this website. So you can see in the States, the take-home message is that whilst the physiology and presumably the pharmacology shouldn't change greatly, the prescribing rates certainly do around the world, and there are clearly questions to be asked about that. Pill mills, mentioned by Bart. I'm sure all of you will be aware of these, but for those that have missed them, something in the newspapers quite often, certainly in the American press. They're defined as clinical facilities that prescribe controlled drugs, substances, usually opioids, outside the expected medical standard. And the argument is you decide you want to get high, so you go and see a willing doctor who'll give you your prescription for your opioid of choice, and then he gets paid and you get high, and they're all happy. Apparently, according to the Drug Enforcement Administration in the States, the center for this is Kentucky, and that more than 7 million Americans use prescription drugs for non-medical reasons, compared to 1.5 million that use cocaine. And I think there are all sorts of discussions we can have offline about those, but it's something to be aware of, and it's certainly something that colours much of the discussion. Right, anyway, this is what you wanted me to talk about, so it's the evidence, and we'll start with the evidence for opioids in chronic pain. I'm afraid there's really very little evidence, and what does exist is really of rather poor quality. So those with pressing engagements can leave at this point. As you know, our top-class evidence comes from our randomised controlled studies. Most of these are in chronic low back pain. Very few of these are run for more than 4 months duration, which isn't very long-term, is it? And they all, by and large, suffer very significant dropout rates. In fact, one open-label study had a dropout rate of 56%. So what are you going to do with your dropouts when you're organising a study? Well, there are a couple of things you can do. One is just ignore them all, use an intention to treat analysis, which certainly has its advocates. Another one is to use an imputation technique, which is where you decide to do something with the data you've got. So if we take our wonder drug X, and we pop a couple of axes on, and we make one a pain score and the other a duration of time, we'll start our trial, we'll finish our trial. We'll get a patient, individual patient, and we'll look at their pain scores. So they start off with a pain score of A, that's the base observation. We give them our wonder drug, and good Lord, look at that, quite significant drop in pain. It is a wonder drug. We'll see them again, and gosh, got even better, amazing. It's a really, really wonderful drug. Then we'll see them the last time, but they don't turn up, they phone you up and they say, it's disgusting, it's horrible, I can't cope, I've stopped it. So then you have a last observation, B, and when you're doing your analysis, one of the options is to take your last observation and carry that forward, LOCF, or use your base observation and carry that forward. So, usually, very often, it's the last observation that is carried forward. But is this right? Perhaps it would be more honest to use the base observation, because at the end of the trial, the patient that couldn't tolerate the medication will be off the medication and their final pain score will be what it was when they started. Another thing to consider in trial design is enriched enrolment. So if you start with 100% of recruited patients, pop a timeline on, give them all a trial of your wonder drug. 60%, for example, will respond. That means 40% haven't. And it's only those 60% that go into the trial. You'll know they're responders. You can then compare with your other drug, whether that be placebo or something else. So that's an example of enriched enrolment. And many people suggest, well, it just creates a bias because it's not the real world. But some people say it is actually the real world, because when you have your patient come in to you in clinic and you provide them with their medication and then they try it and they go off, it's only the ones who respond to it that are going to stay on it, and maybe that gives us a bit more information. Last thing to consider with the trials, I think, is the issue about mental health. Usually in these trials, people with mental health concerns are excluded. And of course, in the real world where you and I all work, it's actually quite a significant proportion of the population we see, so maybe that needs to be taken into consideration. So the point is, when you read about a trial, you need to consider the design of the trial, because the design of the trial will affect the answer that comes out. And I think at one level there's no such thing as a right or a wrong design, but it's varying degrees of what it's going to tell you that you need to consider when you're considering the evidence. So I, like other people, do as much of my work as I can, so I use the Cochrane database very often, so they sift through all the systematic research they can, all the RCTs that they can find, and they give you some nice answers. So I've used them as the primary source of information for these. There's a recent paper, 2014, Oxycodone for neuropathic pain and fibromyalgia. They decided 2 tiers of evidence they were looking for. First tier was either a substantial pain reduction with an intention to treat analysis, and no imputation technique, at least 200 people in each trial, and 8 to 12 weeks duration. The second tier evidence was for any paper that didn't reach all of those but did have at least 200 in the trial. So that shows the importance of trial size. The results, there was no first or second tier evidence found, I'm afraid to say, and the conclusion was that there was no convincing unbiased evidence that oxycodone is of value treating these conditions. What about buprenorphine for neuropathic pain? Well, there's a paper that's still warm, I hope, getting through, and the summary, save you looking for it, is that insufficient evidence to support or refute the suggestion that buprenorphine has any efficacy in neuropathic pain. Not to say it doesn't, but certainly not to say it does. There was a paper in 2013 looking at opioids for neuropathic pain. Short term, up to about 6 weeks, they may help. Intermediate term, no good evidence. For arthritis, a little bit further ago, 4 years ago, 2011, they found limited evidence again that the weak agents may help short term, but nothing for long term, no good evidence for strong agents. Back in 2010, so 5 years ago, there was this paper, long-term opioid management for chronic non-cancer pain, that suggested that if you do tolerate the agents, then many of them may help you significantly, which is probably what we find clinically, I guess, but it's finding the right patient with the drug. Of course, if your RCTs aren't giving you the evidence, where you go to observational studies, and I'm afraid the response is quite short, still no good evidence. So that's the state of the evidence for the use of opioids. What about the evidence against? Well, as mentioned, dropouts is a significant issue. And as you all know, it's either lack of efficacy or because of undesirable side effects. And the number needed to harm, very similar to the number needed to treat, but different. The NNH is about 4.2 in short-term trials. And of course, the culprits are everything Tony has discussed. So it's the constipation, it's the nausea, it's the drowsiness. Now, of course, drowsiness in some of our elderly patients, which make up an increasingly large proportion of most clinics, can be quite disastrous, leading to falls, hospital stays, and unpleasant consequences. And there are also issues now about driving. In the UK, the laws around driving on medication has changed slightly, and although the clinical evidence isn't quite clear, it doesn't matter, it's what the lawyers are telling us. There are, of course, other significant associations we're reminded of regularly. Depression and hypogonadism is often mentioned, but the questions you need to consider are: what are the effects of chronic pain on these? And what's the effect for that specific individual? Tolerance. So you all know what we mean by tolerance. It's you need to increase the dose for the same effect. Very common in some of the low back pain studies. It's seen within a month of being on an opioid. But actually, isn't it just normal biology to a degree? And why should we view it as something wrong? It's just what happens. It's just tachyphylaxis, surely. Hyperalgesia, Tony's mentioned. It's certainly something lots of people talk about. The clinical significance for an individual is very hard to gauge. How much of it is the pain getting worse? How much is it all the other things that happen? Dependence. So this is, as you know, the significant consequences following rapidly stopping a drug. It's common. And it happens with lots of medications. Of course, steroid use is the typical one, isn't it? We've learnt from when we were very little ones that you tail down steroid doses, because if you stop them quickly, it can be bad. So in a way, it's another just normal biological thing. And it certainly isn't addiction, which is what many patients think it is. Certainly the press often suggest it is, and I think some of our colleagues sometimes confuse it. Addiction is the repeated compulsive drug seeking despite adverse consequences. Well, that's different to dependence. Thing is, we don't like to blame ourselves very much. Much easier to blame the tablet for being addictive, but actually addiction is things that we are. We become addicts. We become addicted to nicotine, to alcohol, to sex, to drugs, to driving too quickly, all sorts of things. And I don't see much of a cry to ban sex, but it's nice and easy to ban the opiates, perhaps. And the other problem is that there's been this development of a thing called an opioid use disorder, where people have lumped both dependence and addiction together, and I think that's slightly disingenuous. And it certainly means that some of the opioid addiction data is probably skewed because of the incorporation of dependence in that. Right, this is a really important paper. It's a position paper of the American Academy of Neurology, and it came out last year. It really important. I can't stress enough how important it is. It's changed the way it's certainly crystallized a lot of people's views, and it certainly makes a number of important suggestions. However, on the front page of the article, in the third or fourth paragraph, is this statement: the lobbying effort to liberalize opiate use was so successful that even the Joint Commission on Accreditation of Healthcare Organizations instituted screening for pain as the fifth vital sign. Now, the JCO in the States is a really important organization, and without its accreditation, your organization doesn't do well. So you need that box ticked. But what I would ask you, because you've all heard about the fifth vital sign, do you think its aim is to increase opioid use? Or is it to find pain? Anyway, having read that paragraph, I felt the rest of the paper needed to be taken with a pinch of salt. So, other problems. Well, we've discussed the pill mills. As Bart alluded to, deaths in the States really rather common. 16,500 people in 2010 died to prescription opioid overdose, apparently. I thought I'd find out how many people died in the States that year anyway. It was about 2.5 million, of which 31,000 deaths were related to gun incidents, just for a bit of context. Most deaths with opioids are the result of respiratory depression, but as any addict will tell you, or recreational drug user will tell you, it's usually the result of taking it with other agents such as benzodiazepines and alcohol. So that's the evidence against, but please remember, these are associations and they are not proof of causality. So, in summary, the evidence for these opioids is pretty weak. We know opioids are without risk, just as every other agent we take is not without risk, but we also know chronic pain is not without risk. We certainly, I think, need better trials, and I'm always fascinated that regulators never want to get their hands involved in this side of things and leave it to impoverished clinicians, healthcare organisations that have no money, or the pharmaceutical industry who have their eyes on other targets. And I think you always need to remember the importance of the individual. And if you want more information on that, I'd suggest you look at Andrew Moore's paper back in Pain back in 2013 on that subject, which is beautifully written and is a good reminder to us all as clinicians. But it's not all misery, actually. It sounds all a bit dreary, doesn't it? But it's not all doom and gloom. The British Medical Journal is the British Medical Journal, and it has an impact factor of more than 17, which is quite impressive. And last year it had an editorial entitled "The Evidence Base for Orthopedics and Sports Medicine." And the subtitle was "Scandalously Poor in Parts." So whilst we might not have all the answers and we've still got lots of questions, we're not doing as badly as some of our colleagues, I suggest. In conclusion, no good evidence for or against. Consider the evidence and your experiences. That is what evidence-based medicine is, because evidence and experience makes wisdom. We treat individuals, not averages, please always remember that. And it's a biopsychosocial problem, so what are the chances of a silver bullet answering? Thank you all very much.